Hello, my name is Spencer Asay, and I grew up in suburban Utah. And growing up in that environment, I had no real concept of poverty, inequity, or injustice. But when I was 19 years old, I left on a 2-year Christian mission to Cambodia. And while I've distanced myself from my prior religious ties, my time in Cambodia proved to be a defining life experience in many ways. This is a picture of me with the family that I met while I was in Cambodia. When I met this family, the father had a diagnosis of end-stage renal disease. This was a difficult diagnosis as it was, but to compound things further, the family did not have reliable health insurance and were having immense difficulty paying for the expensive dialysis treatments. Further, the area in which the family lived was relatively isolated and lacked many of the critical community supports they needed, including access to the kind of foods required for a renal diet. The situation was far from conducive to optimal health and well-being. This family's story was a microcosm of what I saw and experienced in Cambodia. Their story, and other experiences during my time abroad, opened my eyes to the realities of healthcare disparities and the various ways in which both an inaccessible healthcare system and adverse community context can impact human health and flourishing. Even more, once I returned to the U.S., these realizations led me to recognize that the very same inequities I'd seen abroad existed in my own backyard. These experiences and recognitions have galvanized me to advocate for systemic change. Ever since I started on my path toward a career in medicine, I've felt driven to seek to make an impact for both individual patients inside the clinic as well as entire communities outside of it. The U.S. health system is in the midst of a long-awaited and much-needed sea change, guided by the principles of the quintuple aim, to create a system that works better for everyone. A desire to be a part of this positive change is ultimately what led me to join DFA and become a part of the Copello Fellowship. Through the Copello Fellowship, I've had the opportunity to contribute to the work of DFA's Access to Affordable Care Impact Area, which focuses on ensuring that patients have equitable access to high-quality health care without the threat of financial ruin that has become all too common in today's system. Through my involvement with this committee, I've learned from passionate advocates and had the opportunity to contribute to impactful advocacy work. One of the main areas of focus of the Federal Legislation Subcommittee of the AAC has been pharmacy benefits managers, or PBMs, and their outsized influence on the U.S.'s unconscionably high drug prices. PBMs have garnered increasing attention in recent years. However, the complexity and the almost complete lack of transparency surrounding their practices has made meaningful reform extremely difficult. Our subcommittee recognized that many of our DFA members were passionate about drug affordability, but didn't have all the facts about the complex and convoluted ways in which PBMs contribute to the problem. We collaborated with the Patients for Affordable Drugs to put on a lunch and learn event that featured a critical discussion about PBMs and what can be done to rein in their outsized impact on drug prices. This event elevated the importance of PBM reforms among the DFA community and served as a nidus for continued advocacy work. My experience as part of the Copello Fellowship has led me to further advocacy opportunities outside of PBMs and even outside of DFA. Working within the Federal Legislation Subcommittee, I learned about opportunities for advocacy through administrative rulemaking. I used these lessons to assist the Society for General Internal Medicine's Health Policy Committee in responding to a CMS request for comments on its proposed hospital reimbursement rules. Many of the provisions our committee supported were ultimately adopted in the final rule, and we're hopeful these new provisions, among other things, will lead to enhanced financial resources for safety net hospitals that care for underserved patients. In addition, during the Copello Fellowship, we discussed the influence of social determinants of health, such as food insecurity, and the importance of community engagement work. I also had the opportunity to network with inspiring co-fellows who introduced me to impactful advocacy opportunities available through organized medicine. These lessons and experiences led me to get involved with the Greater Chicago Food Depository and their local anti-hunger advocacy work, as well as the AMA, where I helped to co-author a policy resolution calling for greater AMA advocacy on behalf of strengthening the Supplemental Nutrition Assistance Program. When it comes to healthcare quality, access, and affordability, PBMs, hospital reimbursement, and social determinants of health are pieces of a much larger puzzle. The system itself and the philosophies underlying how it operates must also evolve. Don Berwick and others have recently written extensively about how profiteering in healthcare is compromising the health of patients and the health of the profession more than ever. Change is needed, and DFA's AAC impact area is well positioned to play an important role in bringing that change about. Having now completed the Copello Fellowship, I feel empowered by the advocacy knowledge, experiences, and skills I've gained to contribute meaningfully to DFA's push for continued systemic reform and better healthcare for all.